So I'm going to start recording now. And please, could everyone make sure that their microphones are on mute, please, so that we don't get disturbances during the presentation. Okay, so tonight's talk is about a very topical subject, which is egg freezing. There's been a lot more coverage in the media and social media, a lot more awareness about it in the past few years, I'd say, especially since COVID. So it's something which many of you, maybe have not heard of until a few years ago, but now is very much being covered in great detail. So what is egg freezing? I mean, in summary, the egg freezing, or oocyte preservation, we call it, is extracting the eggs from a woman to be frozen, and then this process will allow the woman to potentially use her eggs in the future for having a child. Vladimir, my colleague, will go through the techniques in a bit more detail later on this presentation. So big question is really who should freeze their eggs and why? So the beginning of egg freezing was really medical reasons for freezing eggs. Mostly it started off with cancer patients. So there were young women, sometimes even teenage girls, who were then needing to have chemotherapy, radiotherapy to treat their cancer. And of course, these treatments are very harmful to the ovaries, to the eggs, and then could affect this woman's fertility who's still not had children. So the idea was that the eggs should be extracted prior to the chemotherapy or radiotherapy, so that these eggs can be preserved for the future. Or the other thing that they tried was taking a wedge out of the ovary, extracting a whole segment of ovarian tissue to freeze and keep for the future when this woman may want to try and have a baby. So it all started off really for medical reasons. Mostly it started off with cancer. Sometimes there were women who needed to have their ovaries removed for medical reasons or for cancer prevention when they have genes which could then lead to them having ovarian cancer, and some other health issues that would mean that the woman wouldn't be able to get pregnant or may have difficulty getting pregnant in the future. So it started off with medical reasons. Of course, with time, this evolved to then women who froze without medical reason, just for their personal choice. And the big change really came about 10 years ago when the ASRM in America, they kind of removed the experimental label from egg freezing, which used to be considered as an experimental treatment. They removed that label about 10 years ago, and then it kind of opened the door for more women to be starting to do this process. And for personal choice, women would do it. They would choose to delay becoming a parent. It could be maybe because of their career. This is a very common one nowadays. 2 or 3 generations ago, women were mostly having their firstborn child in their late teens or early 20s. But now, of course, this isn't a commonplace, and women are delaying having babies due to career, due to maybe not having a partner, or other reasons which are to do with modern lifestyles. And yes, it's great that women now can have that choice to have a career and fulfill other things, but it kind of took away a little bit the choice of then maybe having a baby if they became too old or they didn't have enough eggs later on. So therefore, freezing the eggs is a form of family planning. I mean, normally when we say family planning, people think about contraception, and yes, that is one form of family planning, but this is a new form now where you can kind of plan your family for the future, and actually, family planning in terms of having a baby, not trying to stop yourself having a baby, which was the traditional feeling for family planning. Some women do it because maybe they have a family history of early menopause, so maybe their mother or their elder sisters have been having menopause at an early age, under the age of 45 or sometimes even 40. And they're scared that maybe if they wait until they are in their 30s that they won't have enough eggs, or they may have also very early menopause. And some women just do it for peace of mind. They just want to have some eggs frozen when they're younger, because then if they do get older and then they have any troubles, these eggs will be there for them to use as a backup. Now, the biggest factor to do with egg freezing is really the age of freezing the eggs, because women are born with eggs. It's not like sperm, which is constantly being produced and made. You are born with your eggs and you just lose them with time. You lose them even before you're born, and even before you go through puberty, you would lose your eggs. And even if you take the contraceptive pill and say, I'm fine, I've not been ovulating for the last 20 years because I've been on the contraceptive pill, unfortunately, you still use your eggs. Now, not only is the number of eggs being reduced, but actually the bigger factor by far is the quality of the eggs is reduced as well as you get older. So especially as a woman approaches 35 and beyond, each year, the quality of eggs does reduce quite a significant amount. And when we talk about quality of eggs, it is the chromosomes, the genetic makeup of the egg, which will then reflect the genetic makeup of the embryo and lead to what we call aneuploidy, which is the incorrect number of chromosomes in that embryo, which then most likely doesn't lead to pregnancy or leads to high risk of miscarriage or abnormality in the baby. So when you freeze in eggs at a younger age, there's more chance that these eggs will be better quality and therefore better chance of having a baby with these eggs. If you freeze your eggs, for example, when you're 30 and then you come when you're 44 to use these eggs, then definitely these eggs will be much better quality than any eggs you produce at that age. So the process for egg freezing is quite complicated, actually. It's not very simple. It's not like freezing sperm, which is a very easy process because sperm is designed to come out of the body. Eggs are really supposed to stay inside. So it's quite a difficult and complicated medical procedure, which ends actually in a minor surgical procedure. So this is something that women need to take account of when they decide to do it, because there are risks and issues and costs involved in doing this. So before the egg freezing cycle would start, then the fertility clinic would usually ask for some baseline tests. Hepatitis B, C, and HIV need to be done in this country within 3 months of starting the first egg freeze cycle. Blood test called AMH, which is a blood test which gives a reflection of the egg reserve. It's not the be-all and end-all of egg numbers, but it kind of gives a vague indicator, which is useful. Vitamin D in this country, there isn't much sun, and it's very easy to become deficient in vitamin D. So low levels of vitamin D can affect the egg quality. And usually the clinic would also want to have a baseline ultrasound scan to look at the ovaries, see how accessible they are for collecting eggs, see how many follicles are there, make sure there's no other issue which could be an obstruction for collecting eggs and getting eggs from this woman. And also blood test checking the hormone levels as well. And then the protocol for freezing the eggs would be finalized. There are different stimulation protocols that can be used. And yeah, the clinic will then decide based on these results exactly which protocol is suitable for that woman. So normally in a menstrual cycle, you just get one egg being produced, but the process of egg freezing would really require multiple eggs. And to get multiple eggs, we ask the woman to take stimulation, ovarian stimulation, which comes in the form of daily injections that the woman would be taught normally to do herself. And typically these hormone injections will be taken for about 2 weeks. 10 to 16 days is kind of the average time. It's injections. The medication still hasn't been developed in tablet form or suppository or any other form. It has to be daily injection under the skin. Sometimes, depending on the protocol, you may need to take more than one injection in each day. And yeah, this is something which may put off some women. Also, another thing which is important is to have some monitoring done to see how these medications are working and if the medication needs to be tweaked. And this monitoring will usually involve blood tests to check the hormone levels and ultrasound scans, which are done transvaginally to check and see the growth of the follicles and how many follicles are growing, which will then give an idea as to how many eggs and how close to being ready for the egg collection this woman is. So this medication that is given will be then adjusted based on the results, and medication instructions will be given to that woman following these tests are being done. So just before the woman is told to have her egg collection, she needs to take a trigger injection, we call it, which is important to mature the eggs, because when eggs are collected, if they are immature, these eggs are not really going to be useful for this woman. So when she freezes eggs, she wants to freeze mature eggs, because these are the eggs that are most likely going to fertilize and make an embryo later on. And in order to mature the eggs, this trigger injection is given, and then we wait for about 36 hours or so before the egg collection procedure will be done. Now, egg collection procedure needs to be done under some anesthetic because it involves a needle going through the vagina directly into the ovary, and then the fluid within the ovary will be aspirated to then hopefully collect the eggs. And it's done as a day case procedure, so the woman usually will be coming, for example, in the morning, and within a couple of hours, she'll go back home. But it does involve anesthetic, so of course, she won't be able to go to work or drive a car or anything that day. There are some risks from this procedure. So small risk of bleeding, small risk of infection, and small risk of injuring the nearby structures, which are the bowel, bladder, and blood vessels. Approximately, it's about 1 in 1,000 risk. Now, the IVF stimulation drugs can give side effects, and these are quite common side effects, in fact. So very common to get bloating and tenderness in the tummy as the ovaries get bigger. But also some women can experience nausea, loss of appetite, breast tenderness, mood swings, sleep disturbance, sometimes allergies to some of the medication. So these are the short-term side effects that can be experienced. And then after the egg freezing cycle is complete, it may take a month or 2, or sometimes even 3 months for the cycle to go back to normal, to regular, for the ovulation to resume. And some women can have some hormone changes for a few months, which can then also lead to things like acne and other changes which are related to hormones as well. So yes, these drugs are quite powerful, they are quite strong, and side effects are not too uncommon with them. But it lasts for 2 weeks usually, and most of the time it is tolerable, and the woman can continue to work and do her daily function as usual. There are some risks with the egg freezing cycle. So first of all, sometimes the medication is given to stimulate the ovaries, but unfortunately the woman doesn't then produce any follicles. And then if she doesn't produce follicles, we cannot get eggs, so we have to cancel the cycle. With the stimulation of the eggs being developed and the estrogen levels will then go quite high, this leads to an increased risk of thrombosis, which means a blood clot developing. Usually it's in the leg or the chest. And this is something which can be dangerous, of course. So sometimes there will be blood thinners given to certain women who are high risk. And certainly we don't recommend long distance flying within 2 or 3 weeks from doing this egg collection procedure. And if you do have to fly, then you should be covered by a blood thinning injection, heparin injection, which your clinic should be able to provide. There's also a risk of something called OHSS, ovarian hyperstimulation syndrome. So when we stimulate the ovaries, sometimes the response can be too strong to the medication, and that can then lead to a reaction which can trigger fluid collecting in the tummy. Fluid can collect in the chest, around the lungs. Sometimes the woman can become quite poorly and even need to go to hospital. Depends on how high her AMH is, so how many eggs she has, and if she has a higher number of eggs, then this is going to be a higher risk. And sometimes there are things that can be done to reduce the risk. So if the clinic is concerned, they may give albumin, which is a blood product, in the form of an IV drip to further reduce that risk. Some clinics use tablets like cabergoline, for example, as well, to have a similar effect. But the most important thing really is to control the medication to make sure that this woman doesn't get too much medication, because the OHSS is really caused by medication. And if you can try your best to give just the right amount and not too much, then this will also limit the risk of ovarian hyperstimulation syndrome developing. Now, when we do freeze eggs, we need to fertilize them in a different way to conventional IVF. So conventional IVF, we do with good quality sperm, and we just put the sperm around the egg in a dish and allow it to fertilize by itself. But when we have frozen the eggs, because we have stripped the outer layer of the egg, we actually need to inject the sperm inside the egg. And it's done with a procedure called ICSI, as you can see in this bottom right picture here. Now, with ICSI, it has been found that this slightly does increase the risk of congenital abnormalities in the baby, and that's compared to natural conception. Now, most of the time when we do ICSI, it's because of poor sperm parameters, if the man has abnormal sperm. But with frozen eggs, even if the sperm is good, we still need to do it. And we're not sure why this slight increase of congenital abnormality is occurring. But even with ICSI, it doesn't guarantee that the eggs will fertilize. So we aren't sure 100% that we will get eggs fertilized. And it's not unusual that some of the eggs don't fertilize. And with frozen eggs, it's typically 70 or 80% that will fertilize. But sometimes it can be that it's very poor fertilization, none of the eggs fertilize, none of the eggs survive the thawing as well. If you do come back to use these eggs, then this would be classed as an IVF pregnancy, and therefore there is a slightly higher risk for pregnancy complications. Pregnancy complications will include early pregnancy, like multiple pregnancy, miscarriage, ectopic pregnancy, which is where the embryo can implant outside of the womb, usually in the fallopian tube, and that can be quite risky. It's 3% with IVF compared to 1% with natural pregnancy. But also even late pregnancy complications are slightly higher with such treatments, and things like preeclampsia, which is high blood pressure and protein in the urine developing in late pregnancy, growth restriction of the baby, preterm birth. These are all slightly more common, and therefore if a woman has frozen her eggs and is still of an age where she can try and conceive naturally, then she shouldn't rush back to use these eggs. She should try and have her baby naturally, or babies, and hopefully, she'll manage to complete her family naturally, and that's the best way to get pregnant. But if it does happen that she's not got enough eggs, or the eggs are too poor quality, or she's too old, or even if she's menopausal, then she can fall back to use these eggs. So just a few points that I think are important to note. It's not an insurance policy. There's not a guarantee of the baby. Even if you freeze 20 eggs, even if you freeze 80 eggs, we can never say to you 100% that you can have a baby. And Vladimir is going to show you in a few slides how the results look for egg freezing in regards to egg age and number of eggs being frozen. Another thing which is important to realize is that when you have frozen your eggs, there is a yearly cost for keeping the eggs frozen. So typical cost for an egg freezing cycle in the UK varies from clinic to clinic. Some clinics will charge £3,000 or £4,000. Some clinics will be more, like £6,000, £8,000, even £9,000 it can be for one cycle of egg freezing. But then once you've frozen the eggs, you will need to pay each year to keep them frozen. And again, most clinics will charge between £300 and £500 a year for this. So it's important to bear that in mind. Most women actually don't need to use the eggs. Like I said before, if you do freeze your eggs and you're still able to get pregnant naturally, then you should aim to have a natural pregnancy, and hopefully you'll complete your family, and then you can tell your clinic, thank you very much, I don't need these eggs anymore. But yeah, most women actually don't end up using the eggs, and there's a lot more eggs frozen than those which are going to be used. And then IVF clinics, usually they are catering for couples who are trying for a baby. And this is important to understand because most women who freeze their eggs are actually single women. And they don't usually have a separate facility for single women where they can, have separate waiting areas or separate buildings, etc. So you should expect that when you go to the IVF clinics that there will be mostly couples who are trying for a baby, a lot more than there will be single women. Okay, so I'm going to pass over to Vladimir now, who's going to talk about the history and the results and techniques for egg freezing.
Hello, everyone. And yes, so I will be discussing egg freezing in terms of embryologist point of view. And as a scientist and working in the embryology lab for many years now, I'm still wondering how much eggs and embryos can endure. And actually, the fertilization and the embryo development is now quite successful outside of the body. And so my colleagues many years ago before did wonder how, like if they can actually do that. And first step was to freeze sperm, which is the cell almost without cytoplasm and endures freezing very well. And as you may know, in 1978, first IVF baby was born. 8 years later, a baby born from the frozen eggs. Then the scientists used the technique with the slow freezing, when we gradually lowering the temperature very slowly, and at the -7 we start kind of rapid freezing. However, the technology developed in 1999, first baby born from vitrified eggs. And vitrification is when you basically putting egg through the solution and just plunge in liquid nitrogen as fast as you can, and it freezes and becomes kind of a glass stage. In 2000, so it is already quite recently, HFA, they officially allowed to be used frozen eggs in treatment in UK. And as Dr. Sami mentioned, in 2013, American Society for Reproductive Medicine lifted the label experimental on egg freezing. And since then, due to the rapid development of technology, and also due to social media announcements, it became much more popular. And as we see, even 1 year later, in 2014, Apple and Facebook announced egg freezing as benefit for female US employees. And egg freezing becoming much more popular kind of exponentially. Next slide, please. So, and if we go in the details, as Dr. Sami mentioned, we would collect the eggs, and they would be surrounded with the cumulus cells. So to freeze them, we would have to clean them within an hour or two from the cells, and again, nowadays most of the clinics, 99% or even more, using vitrification as a method of choice to freeze the eggs, as it is most successful for these cells. And it's good to mention at this point that the eggs are more fragile and more susceptible to any they can basically lose the quality due to the changes in an environment fairly quickly. When the embryos at any stage, they have already mechanism to tolerate any some changes. So we have to be very careful with the eggs. And during the freezing process, and good to mention as well that the egg is the biggest cell in our body, so it has lots of cytoplasm, lots of water inside, and the freezing process is based on idea to remove as much water as we can by putting the egg through the solution with increasing concentration of the cryoprotectants. Also, some cryoprotectants will go inside the cell to protect it from the ice formation. So if we leave too much water inside the cell, then during the freezing, the water will form ice crystals, which will destroy the cell. And the thawing process is just the reverse process of the freezing. Next slide, please. After freezing, eggs will be staying in liquid nitrogen, and liquid nitrogen has minus 196 degrees Celsius. They can stay there for many years, and we know that they can even stay 10 years or even more. But we don't have much statistic about how that it would affect the egg quality. If it stays for only a few years, so far we don't see any difference, but we need to accumulate just more data for a longer storage. And as Dr. Sam mentioned, a majority of the patients who froze the eggs, they didn't come back yet for the thaw. And the survival rate expected to be could be 97%. Again, very important factor would be patient age, and also experience, like how experienced the laboratory as well, and many other factors. It's also important to mention that the freezing and thawing, it's still a stress for eggs, and it doesn't make them better. We are advanced, and we have quite high survival rate and fertilization rate and cleavage rate, and they go to blastocyst, but it is still a little bit lower than with fresh eggs and fresh embryos. Yes, please. So unfortunately, for UK, there is lots official data fairly old, but they're quite representative. And the advantage of the official data is it's a national register, so we can see on average between all the clinics in UK what was the success rate with the frozen eggs in 2016. So when with fresh eggs, the success rate was around 26%, With frozen, it was 18%. That mentioning that it was patient-owned eggs. If the patients used donor eggs, then the success rate was higher. It was 30%. And we can see that the majority of the patients used donor eggs, as 65% of them. That eventually may change from 2016 because social egg freezing becoming much more popular, and it's much more advertised in the social media. And then if we take all the frozen eggs thawed, around 49 of them fertilized. And as I mentioned, that the majority of the eggs are still not used. Also, this statistic was based on a very small group of the patients. It's only 178 patients had the embryo transfer with the frozen with the embryos created from the frozen eggs in 2016 in UK. Next slide, please. So, but the global trend is that every year egg freezing becoming more and more popular. The number of cycles of egg freezing cycles increasing sometimes about 10%, sometimes 40% a year, but on average it's 20-30% a year. And it's happens like for at least last 15 years from basically introduction of vitrification to the global marketing. So, and still the global trend is that most patients still who froze the eggs previously didn't come to use them. So for various reasons. Yes, please. And what we can see from United States, for example, the country where the egg freezing is very common now, that it is very age dependent how many eggs you need to achieve a live birth of a baby. So if you would like 70% of the chance and you are 29, then you basically with 20 cryopreserved oocyte you will have 94%. So it is very high. Nothing is 100% is in medicine and in IVF as well, but 94% is very good data. So then when the patient is 42 years old, unfortunately, you would need around 60 eggs. So it is increasing exponentially due to the reason Dr. Sami mentioned, decreasing egg quality itself. It's becoming more fragile and less, we would expect less good quality embryos. And also there is would be an issue with chromosomal imbalances at this point. So, and if we go to European register, next table, then we will see very similar trend. Those are not actual statistic presented on taken from the patient, but it is a calculation model to help patient and physician to understand patient chances and plan for the future. So it is not I would repeat again, Dr. Sami, that the egg freezing is not a guarantee, and even with 20, 30 or more eggs, it is unfortunately still a possibility that the patient may end up with no baby. That therefore patient need to plan the family very carefully. So, and I think we mentioned most of the aspects of the embryology with the egg freezing, and I would be happy as well to answer any questions.
Thank you so much, Dr. Sami and Vladimir, for such an incredible presentation and so informative. And we have some fantastic questions, and I will just start to address them one by one. So the first question, if a woman has always had vitamin D deficiency, but then starts taking supplements, does that mean that she can increase the quality of her eggs?
Okay, so I'll just go through this one. The vitamin D deficiency is very easy to test. It's just a blood test, and it's very easy to treat. You just take vitamin D tablets, but it does take a little bit of time if you're very deficient. So, deficiency is a spectrum. It might be just slightly under, which is not such a big deal, or it may be a very severe deficiency, which is more significant in its effect, not just on egg quality, but also on the woman's health or the person's health. So she can increase the quality of eggs, not in terms of the chromosomes, because that's going to be fixed, of course. So if, someone who's older, 44, 45 years, and she treats her vitamin D deficiency, it's not going to fix those chromosomally abnormal eggs. But there are other aspects to the egg which may improve with healthy diet, lifestyle, taking things like vitamin D, cutting out alcohol, not too much alcohol, smoking, of course, or recreational drugs, or, too much caffeine. So a woman who is looking to do egg freezing should try and get herself in the best health, try and achieve, an ideal weight, healthy diet, healthy lifestyle, maybe worthwhile taking some supplements and checking things like vitamin D to make sure that when she does come for the egg freezing cycle, she is in the best health that she can be, and hopefully that will then also help with the eggs. But like I said, it won't change the chromosomes, which is the main thing. And these lifestyle changes, if you can do it for at least 6 weeks, it's good. But if you can do 2 or 3 months, even 4 months, it's better.
Fantastic. Thank you so much. And we have the next question that is there any way to preserve egg quality as you age, and what specifically can be done as we are getting older for that? And also the same lady is asking if actually the medications that a woman has to take to stimulate ovaries can trigger Hashimoto's syndrome.
Okay. So, I mean, you can make the egg quality worse if the lifestyle is bad, if someone is, smoking or abusing recreational drugs, or, I mentioned in my talk, things like chemotherapy, radiotherapy, all of these things will affect the egg quality and also the egg count. So it's important that you try and live the healthiest life that you can. But even if you have been, a model of health, and, you've not done any drugs or alcohol or caffeine or anything at all, sadly, as you age, these eggs will start to deteriorate in quality and the number will drop, and there's nothing you can do. It's an aging process, it's biology, and there's nothing you can do to prevent it, and there's nothing that you can do to preserve the number of eggs either, which is possibly where egg freezing comes in that ideally you'd freeze the eggs at a younger age. And if you have a good number of eggs frozen at a younger age, then this may come in handy if you do end up being older, which is becoming more common nowadays, that, in the fertility clinics, we're seeing more women who are late 30s, early 40s. This is the biggest group of people that come to fertility clinics. We don't see that many women in the early 20s. Yes, there will be some, and it could be things like male factor or tubal. But still, the biggest group of women are the older women, or, in terms of fertility, older women. So the egg freezing may then come in handy if you have frozen eggs compared to eggs that you may produce at that age, if you are still producing eggs. Now, the second question about Hashimoto's. So thyroid function is important as well. So if you have got Hashimoto's, it's important to get this checked out, because Hashimoto's is an autoimmune thyroid condition, and there will be fluctuation how your thyroid function is. So you need to check with your GP or your endocrinologist to make sure that before you start any egg freezing or IVF, or even just trying for a baby naturally, that your thyroid is under good control to hopefully, again, have the best chance.
Thank you so much. And a very interesting question regarding the AMH hormone. So if AMH is 5 times higher than the norm at age of 25, does it mean this will continue to be the case at age of 35, 40?
Okay, yeah, that's a very good question, actually. So the thing is that sometimes some women, they'll do an AMH when they're 25, for example, like in this case. And they're told, okay, your AMH is great. And then they think that maybe in 10 years it's going to be almost as good or just as good. Of course, that's unlikely because there will be loss of eggs as you get older. That's inevitable. But I believe that very strongly that some women are born with more eggs and some women are born with fewer eggs. So if you are 25 and your AMH is really low, then that might be more of a trigger to freeze eggs at an earlier age if you're not planning to have a baby soon. Then for someone who's 25 who has a very good AMH and she could probably hang on for a few years before she decides to freeze her eggs, maybe worthwhile every couple of years or so just having another check AMH to make sure that things are not declining too rapidly. But there are things that can happen which we don't always understand, which can then trigger a rapid decline in AMH. I mean, rapid doesn't mean months, it means years, but still, it could be that someone has got good AMH and then once they hit 35, 37 or whatever age it is that happens, the AMH can drop fairly fast after that. So you can't plot a graph and say, okay, my AMH is this at this age. That means at this age, my AMH is going to be so much. Unfortunately, there isn't anything like that in medicine.
Thank you. Thank you so much for explaining. And I was actually reading myself, and it would be really interesting for myself as well to find out the answer. So, what type of congenital abnormality is related to ICSI? As we all know, if we do have frozen eggs, then it's inevitable that eggs has to be fertilized through the more invasive approach. And that would be just really interesting to understand if there are any risks related to that.
Okay, so I mentioned that when you do ICSI, it does slightly increase the risk of congenital abnormality. And I don't want to cause alarm here. It's a very slight increase. We do ICSI all the time, and it's thankfully very rare that we see babies born following ICSI with congenital abnormalities. In fact, in some countries like in the US and some of the Middle Eastern countries, all IVF cycles are done pretty much by ICSI. It's actually uncommon to do conventional IVF. So there have been so many babies born through ICSI, and there are a few studies that have said there's an increased risk of congenital abnormality, which means structural problems, cardiovascular, which are heart defects, gastrointestinal defects, neuromuscular defects. These are all structural problems, things like cleft lip, cleft palate, which are slightly increased by ICSI. And they estimate about 1.5% increase, which is not a very high increase. Even with natural conception, these things will still happen, of course. There was also some research which showed an increase in something called imprinting disorders, things like Angelman syndrome, or there are a few of these very rare syndromes which had been linked to ICSI, although there are studies that have been done which show that it doesn't really increase. And I've been doing IVF with ICSI for a long time now, and I can't remember seeing any of these syndromes actually in any of our patients, which is good. So I don't want to cause alarm here. There is a slight increase, and I think people should be aware. And even this slight increase isn't 100% proven. Possibly some of it is to do with the fact that people who do ICSI usually are having infertility and perhaps have some genetic problems, especially with the man, because when we do ICSI, most of the time it's because of male factor. And maybe that's playing a role in the increased abnormality rate. So we're not 100% sure what it is.
Thank you so much. That's so interesting. And the next question is, I think, Vladimir, maybe you can explain it. So does the egg freezing or thawing process actually impact the quality of the eggs negatively? And then the same lady is asking if the clinic is required by law to destroy any frozen eggs that are no longer wanted or needed by the patient.
That's a good question. And yes, unfortunately, the egg freezing and thawing, it's additional manipulation and putting eggs through the stress to the point when some of them we expect not to survive freezing and thawing. And eventually, we may see lower fertilization rates and the embryo developing at a different rate in comparison to fresh eggs. But also it's sometimes difficult to assess because all what we can do is look at the egg and say it's look good or it doesn't look great. So we can't look inside and we can't really see what changes caused inside. However, at the moment we already reached a high percentage of the eggs to be survived after freezing and thawing, and fertilization and embryo development is a little bit lower, but very close to the embryo development when fresh eggs used. So, and with the law is obviously it's different from country to country. In UK, it's one of the strictest requirements. So patient has to complete consent and tell us for how many years they would like to store. Initially, it would be only 10 years maximum. And if they decide at any point they don't want the eggs, and their options is either to destroy or to donate to research. It is possible as well.
Thank you so much, Vladimir. That's very clear, and I think it's actually a very important aspect to understand what kind of legal rights we do have and the obligations from the clinic perspective. And so the next question: how long do you recommend waiting between egg freezing cycles?
Okay, so just to add in one more point for the previous question with regards to the quality with thawing. So with egg freezing, the effect is more when we freeze and thaw on the single cell, which is the egg, compared to an embryo freeze. And mostly what we're doing is embryo freezing in most of the time with the IVF clinics, but the embryo survives better the freezing and thawing process. So egg freezing tends to be more for women who are not in a stable relationship or single women. Those who are married or in a stable relationship, they tend to prefer to do the embryo freeze because that then leads to better success rates and better survival rates, etc. So that's something to bear in mind as well. If you're single, then yes, you have the flexibility with the egg freeze, or if your relationship isn't very stable. But otherwise, if you are in a stable relationship, you're probably better off doing an embryo freeze where you use sperm to make an embryo and then freeze that. So with regards to the question, how long to wait in between egg freezing cycles? So typically you would need to rest the ovaries for a couple of months. Now, more recently, in the last few years, we're starting to offer something called a duo stimulation, which is where in the same month, you could go through with 2 cycles of freezing back to back. So you have typically 2 weeks of stimulation, collect those eggs, freeze them, and then pretty much straight after, you'd restart the medication, create a new batch of eggs, which will then be collected and frozen again. And that can shorten the time that you need to be able to get more eggs, basically. And again, this started off with the cancer patients, with the chemotherapy patients, because often the oncologist will say, look, we're only going to give you 3 or 4 weeks, and then you have to start your chemotherapy. We can't really postpone it more than that, otherwise it's more risk for your health. So the IVF clinics had a bit of a timeline, and some women who didn't need the chemotherapy, they weren't producing very many eggs. They'd only get 2, 3, 4 eggs. And therefore doing another cycle would benefit them to get a better number. And this was started, and it seemed to be working quite well. And sometimes some women do better actually in the second stimulation, and sometimes they do worse or the same. So this is another option which some clinics may offer as well.
Thank you so much, Dr. Sami. And actually, quite important question. So, what kind of supplements usually advised to be taken during the egg freezing, and particularly is DHEA or melatonin is advised to take during the egg freezing process?
Okay, so I mean, melatonin, it's not clinically proven for sure yet that it helps egg quality. So, you can take it. I'm not sure it will help. Not sure it will harm either. So if somebody wants to take it, I'm not against it. DHEA, which is a male hormone, it's an androgen, and this may be useful, especially we tend to use it more for maybe slightly older women or women who have very low egg reserve, because the androgens or the male hormones are produced from a woman either from the adrenal gland, but mostly from the ovary. And as the ovaries get older or weaker, the amount of androgens being produced will reduce. And therefore, what we normally do is we do a blood test to check the testosterone level and the DHEAS, which is a metabolite for the DHEA, levels in the blood. And if they are sufficient, then we don't really see much benefit in taking DHEA supplement. But if they are low, then it may be that there's some benefit to take the DHEA for 6 to 8 weeks before starting the egg freezing, just to build up the androgen levels, which has been in some studies showing that it may then slightly improve the percentage of follicles which then grow, and therefore the number of eggs that this woman may produce. It's not proven, again, it's not something which is 100% for sure, but it can be used. Now, DHEA does have side effects. It's a male hormone, it's an androgen, so it can give, especially common, I'd say, the skin changes. So oily skin, acne, increased facial hair, sometimes body hair. So sometimes these side effects can be quite unpleasant. So we don't tend to give it unless there is actually a deficiency of androgens, because otherwise the androgen levels can go very high and there's more chance of getting these side effects.
Thank you, Dr. Sami. And we have just a few more questions. Can the egg quality be tested at any point, either straight after the egg collection or at the point of freezing or thawing? And the same lady is also asking the question, does the egg freezing and the medications used during the process, can those affect the AMH level, potentially reduce it?
I may answer first question. We would like to test the eggs, but to answer short, we don't do that, as basically maybe in the future it will be possible. So before, many years ago, we did test a small part of the egg. It's called polar body. It's a small fragment which would not belong to the egg itself, and it would has same number of chromosomes as the egg. So by testing the polar body, we would know how many chromosomes remaining in the egg itself, and we would have a rough idea about the number of, like, if the egg is chromosomally normal or not. Also, it was used for pre-implantation genetic testing for any inherited disorders, like thalassemia, for example. So same technique we would be able to test, but because now with the embryo testing, we can do the same, and it's less invasive and sometimes more accurate. So we sort of abandoned the egg testing for this reason. So eventually it's remaining only assessing the egg by its visual appearance, which is obviously not very accurate. We can't base on that accurate prediction what's going to happen next. So they may look different, but still may create a good looking embryos. Dr. Sami?
Yeah, so the other half of the question was, do stimulating the ovaries and collecting eggs, for the medication used for the egg freezing cycle, which is the same as in an IVF cycle, do these treatments then lead to a reduction in AMH or egg reserve? And this is a common misconception, actually, that people think, okay, you collected 20 eggs from me, and if I just ovulated myself, I would have just lost 1 egg. Now I've lost 20 eggs. That's going to have a big impact now, especially someone who's doing repeat cycles on my egg reserve, and maybe I'm going to have an early menopause, etc. So there's no proof that doing IVF stimulation, whether for egg freezing or IVF itself, will lead to early menopause or reduction in egg count. Now, the reason is, each month when you are going through your menstrual cycle, there will be a number of follicles, which we call antral follicles, that we can see on the ultrasound scan. And each of these will usually contain an egg, and only one of these would be selected in that cycle to then grow and develop and then release a mature egg, which would then be, hopefully fertilized for an embryo. The rest of these antral follicles, which could be 5, it could be 10, 15, 20, even more sometimes, the rest of these would all just die off. They will just disintegrate and die off, and then there'll be a new batch in the following cycle. So with the IVF stimulation, which we use for the egg freeze as well, we try and make use of these eggs which would have been lost anyway, and try and collect these eggs which would have been lost anyway. So you're not actually damaging your egg reserve or lowering it any further than what would have happened naturally in any case. In a similar way that some people, they come to me in the clinic, they say, oh, why is my egg reserve so low? I've been taking the contraceptive pill for 15 years now, so I haven't released any eggs for 15 years. Well, unfortunately, you still lose the eggs like in the way I've just described.
Thank you. That's such a great explanation. And I think we just would like to know that, just going back to statistics, so what's the percentage survival rate of eggs from the thawing process? And the same lady is just very interested about the PRP process, if that can help to increase the success rates of egg freezing.
Okay. So with the statistic, if you go online, you often find the success rate like of the egg survival is as high as 97%, but this would more relate to the donor eggs from very young patients. But to my experience and experience of my colleagues, anything above 70% is fairly good. So if 70% of the eggs survived is considered to be okay. If it's 80 or 90, then it is perfect.
And then going to the PRP question. So PRP is platelet-rich plasma. And this is a treatment which started off actually being used for orthopedics, injuries, sports injuries especially, where they will take some of the patient's blood, they spin it down, they centrifuge it very fast to separate it into layers, and then one of these layers is the platelet-rich layer. It will be extracted and then injected into the wound, or in this case into the ovary, or it can be used in the scalp for hair loss, or for many other things, for wound healing, because this PRP layer is very rich in growth factors, which can stimulate growth of cells and development of cells. So PRP for the ovaries has been used for a few years now, and it's involving this PRP layer being injected into each ovary with equipment very similar to the equipment which we use, well, pretty much the same equipment that we use for the egg collection, which is why it's maybe a useful time to do it at egg collection. The process is only done usually, though, for women who have very low egg reserve. So if a woman is really struggling to produce eggs, whether for IVF or for egg freezing, then this may be considered. It's not something which is easily available in the UK. So a lot of times patients are having to go to other countries to do it. I think it will be more available widely in the UK soon, in the next year or so. I'm sure it will be more widely available, but for now, it's not so easy to get. It's quite costly. It involves the same risks I described with the egg collection, so bleeding, infection, injury to bowel, bladder, or blood vessels. And the cost is also, fairly high. Usually it will cost around 1,800 euros if you do it in Greece or Spain. It depends, I suppose, when you do it, because also they will include anesthetic fees and day stay fees, etc. So for someone with a good egg reserve, I wouldn't see why they should need that. It's only for low egg reserve patient. And if the egg reserve is low and they do decide to go for the PRP, it's a temporary effect only. So it takes a couple of months for the PRP to actually work to stimulate the ovary, and it wears off at 5 months. And the success rate, again, is not 100%. It's about 30%, maybe up to 40% of people who've had this procedure actually who will benefit. So there's going to be a lot of people who do this procedure and it does nothing at all, unfortunately. So something you can discuss with your doctor, with your reproductive medicine specialist, to see if they feel that this is something that would benefit you or would help you. Still not very easily to get in the UK, so not all clinicians here will have experience with it. I've actually had some experience when I was working in Barbados. I did quite a lot of PRP in the ovaries, and I would say that one of the best times to do it is at the egg collection. So I did see a few women who were coming at a younger age to freeze their eggs because they found that their AMH was low. They were, late 20s, early 30s, and yet they had a really low AMH, which meant that doing the egg freezing cycle, they would only get 2 or 3 eggs with great difficulty. And then when I would collect the egg at the end of the procedure with the needle still inside the ovary, so it doesn't add any extra risk or cost or anything, I would then use the PRP in each ovary to inject a little bit of the PRP, and then ask the patient to come again in a couple of months for a repeat round of egg freezing. And sometimes we would get more eggs in the second round, but not always, in fact.
Thank you so much. And we just have a few more questions, and I will just join 2 questions. The lady is asking, so what advice would you give to someone in their late 30s who doesn't have a partner but wants to have a family and is struggling to make a decision as to whether to freeze eggs or not? And would it be an AMH that patient should do at first instance just to make this to help you to make this decision? And actually, if you could maybe just clarify, can AMH be impacted by the stress or other factors, and what exactly affects the AMH fluctuation?
Okay. So AMH, anti-Müllerian hormone, is test which has been around for about 15 years now, and it made life a lot easier for patients and for doctors because you can do it at any point in the menstrual cycle. Prior to this, we used to rely on the day 1, 2, or 3 hormones only, which are still useful, I feel, and important. But this AMH is useful in that you can do it at any point in the cycle. It gives an idea. It doesn't give an exact number. So, you come back with a number which could be 3, it could be 10, it could be 80. But that doesn't tell you have 80 eggs. It just gives you a kind of a vague idea that if the AMH is high, that there will be more eggs left in the ovary, and if it's low, there'll be fewer eggs. It's not 100% accurate either. And you could do an AMH today, and it could be, for example, 3. Could do an AMH tomorrow, it could be 5. You could do an AMH the next day, and it could be 2.5. It's not that the egg count is going up and down. Of course, it won't go up, it'll only go down, but it just gives a vague idea. You won't get an AMH which goes from 3 to 30. That's not going to happen, or there must be some error if that's happening. And also, you have to check the units because in different countries they use different units for AMH. So if you're doing it in different countries or different labs, you need to make sure when you're comparing AMH that you're using the same units. But the fact is that AMH will drop ultimately as you get older, and it won't be affected so much by things like stress, short-term stress, things like that are not going to affect it. It's going to be more affected by things which affect egg quality, mainly number 1, age, but then things like we said before, smoking, drugs, chemotherapy, radiotherapy, alcohol, surgery on the ovaries, endometriosis. Some women who have endometriosis will have cysts forming on the ovaries, and these cysts can actually also lead to damage the healthy ovarian tissue, which can then drop the egg reserve. So these things over time will eat away at the egg reserve, and therefore the AMH will drop. Now, for this lady who's in her late 30s and still hasn't got a partner, but is hoping for in the future to have a baby at some point, yes, I agree. The first step is to do an AMH and to get other assessments to check the egg reserve, because I don't think personally that AMH is going to give the whole picture. I prefer to do other tests like an ultrasound scan, so you can count the antral follicles in each ovary and make sure that the ovaries are in a good position. Also, you could do a blood test with the beginning of your period, checking hormones like FSH, LH, estradiol. That also gives an idea about the egg reserve, and this is something which also gives an idea for me as to how responsive the ovaries are going to be at the beginning of the cycle. So yes, I would say it's a good idea for this woman to think about having some fertility testing done, just to kind of understand where she is. But regardless of whether her AMH is low or high, she still may want to consider egg freezing, because things are not going to get better. And if she doesn't feel that in a year or 2 it's going to be that she's going to be trying for a baby, it's wise to have some eggs frozen for if she does meet a man in a few years and she wants to try for a baby, she can use with this man these eggs which are frozen, rather than being 40, 41, 42. And then not just the egg count is reduced, but also the egg quality will be such. And ideally, when you freeze eggs, you freeze at a younger age, ideally 35 and under, but 38 is still not too old to do it. You still would get some good quality eggs. Hopefully, if you have a good number, then that would be giving you something useful for the future. And if you don't have a good number, if your AMH is low, you may have to factor in trying more than one round of IVF stimulation to get more eggs to freeze, because that's going to give you a better chance rather than just freezing 2 or 3 to try and get more.
Thank you so much. And just to finalize on the webinar, just the last question. Could you just, Dr. Sami, clarify? So does actually long-term usage of the contraceptive pill can impact the actual quality negatively of the eggs?
No, it won't impact negatively the egg quality. But the misconception some people have is that it will preserve the egg number, and that's definitely incorrect. Now, I'm not a big fan of women taking the contraceptive pill long-term for so many years, because the problem with the contraceptive pill is it gives you an artificial period. And if you've been taking for 15 years this contraceptive pill non-stop, you've not really had the opportunity to see is your body working properly, is your reproductive hormones still there. And I've seen before where some people, they've stopped the contraceptive pill and actually they've gone into an early menopause. They didn't realize it because they've been on the pill for 20 years. And when she's 41 and she decides she wants to have a baby, she stopped the pill and there's no period coming, and she's told to wait because she's been on the pill for a long time, and that can delay, of course, a cycle coming for several months. That's normal. But after 6 months, a year and a half, there's no period, and then when suddenly she does tests and evaluations, she realizes she's menopausal, and I have seen that before quite a few times. So I think it's good to use a contraceptive pill. I'm not against it at all. It's a great tool to have, but I'm not a fan for someone just to take it non-stop for many years without giving themselves a break to see kind of what's going on. And I think that the menstrual cycle itself reflects a lot of things with regards to women's health that she's missing out on by getting these artificial periods.
Thank you so much, Dr. Sami. And I think it's such a valuable advice, because we do go to our GPs, and and we do want to protect ourselves from the unwanted pregnancy, and we prescribe the contraceptive pills, but no one actually even mentions to us that, oh, actually the hormones needs to be checked time to time, just to make sure that we do have a control of our ovarian reserve. So that's very important to know. Thank you. And just the last question, so what number of eggs would actually make clinic suggest to cancel an egg freezing cycle, or maybe not an egg number itself, but the follicle number during the stimulation?
So yes, I mean, when we do the scans during the stimulation of the ovaries, we will get an idea as to how many large follicles are developing, which are those that then are likely to produce the mature eggs that we can then hopefully freeze. So it gives an idea from the later scans, which are done during stimulation, as to how many eggs. It doesn't give an exact number though. And it's not that common that we cancel IVF or egg freezing cycles, because usually before we start, we will have some evaluation, we'll have an idea, we'll be able to counsel the patient, give them an idea. If we think we're not going to get any eggs, or she's not going to respond, or just maybe 1 or 2 eggs, then most of the time we don't end up starting it from the beginning. But if it is a patient who we expect only to get 1 or 2 or 3 eggs, and she wants to freeze them, then we can freeze them. We won't stop someone going through the process if they're happy with the fact that they just may get a couple of eggs, because the reality is that they may try again a few months later and it may be exactly the same. Even if we do everything we can, we don't always get a better response. Now, sometimes, however, it comes as an unexpected thing that we kind of think that this woman is going to produce 7, 8, 10 eggs, as a rough estimate, and then we're only getting 1 follicle growing, and it seems a bit wrong then maybe to go through the whole thing with just that 1 follicle for egg freeze. So in that kind of situation, we might counsel the woman and say, look, this is a bit unexpected. Maybe it's just a funny month, and with these things we can never predict 100%. And perhaps it's worthwhile just stopping now and trying again another month, maybe slightly adjusting the drugs and the stimulation protocol to see if we can get more. And we can never guarantee, but it may be worth it at that point. But there's no way we can ever predict exactly how many eggs a woman is going to produce. Even if the AMH is high, sometimes we don't get very many eggs. It can still happen.
Thank you so much, Dr. Sami. And just on this note, I just would like to summarize our webinar and just to say Thank you for coming and joining us tonight, and I hope we did answer all of your questions. If you still have questions, you always can come back to us. You can email to us at info.planyourbaby.co.uk, or you can message us through our website, and we will WhatsApp you back if you have more questions. And you always have opportunity to book a 15 free minute call with one of our senior nurses. Thank you so much, everyone.